Hi, welcome to the Henry Schein Thrive Live event talking about 3D speed reading and referring, a simple method to evaluating cone beam CTs. I just want to thank everyone so much for the introduction and thank you guys today for joining me. So today we're going to talk about a simple method to read our cone beam CTs. And with that simple method, we have a systematic approach to evaluating our images. We want to remember our interpretation principles, including all of our radiographic signs as we're going through. And we want to think about management of our incidental or pathological findings. We can also use our cone beam CTs, of course, to plan the overall treatment plan. There's so much that we can do with our images. And learning. We always want to keep learning. I think anytime there's any new technology out there, we want to take additional courses to be able to better understand what it is that we're looking at, particularly radiographic anatomy and pathologies. We also know that cone beam CT is a fantastic educational tool for our patients as well. And finally, we want to discuss ethical and legal considerations, what you need to know as the dentist. So, the very first thing, we want to think about a key to successful interpretation. And it's very important we start with a diagnostic cone beam CT. What does that mean? Well, that means that we can actually visualize what's occurring in our scans. It is possible with some of our technology to actually have image quality that is too low or to unfortunately mismanage the amount of radiation or the settings that we put in for our patients. So, for instance, if you were to use a pediatric setting for an adult, you would probably have increased noise in your image because you don't have enough radiation hitting the receptor. So you want to actually make sure that we have the appropriate exposure setting for each case. We also want to make sure that there's not motion artifacts. So number one thing, look through it, make sure you have a diagnostic image to evaluate. If it looks like you can't see anything in the scan, you might want to go back, reevaluate your settings, make sure you've taken it appropriately, and make sure there's no motion in that scan. We also want to have proper viewing conditions. So we want to make sure that we're in a low light situation so that we can pick up any of the nuances, any of the little gray value differences in our scans. We want to understand our normal anatomy, have kind of a mental picture of normal anatomy, as well as a knowledge of head and neck pathology, which many of us have already, but maybe just brush up on that a little bit. And we want to have a systematic approach to evaluating everything. Just like you have a systematic approach to looking through a panoramic or maybe looking through your intraoral full mouth series, we're going to have a systematic approach to how we tackle our cone beam CTs. So again, systematic approach, taking into account all of the patient information as well. We know there are certain pathologies that may reside within certain age groups or within certain genders, for example. We want to look at a history of what's going on with a particular region of interest, maybe symptoms, maybe the patient's had pain, a clinical examination. For some of our pathologies, we'd like to know that there's pain and drainage versus no pain and drainage because that helps us know if we're looking at something that's maybe inflammatory versus something that's malignant. So taking all of our clinical examination as well as the patient's symptoms into account is important. Look at existing diagnostic radiographs. Have there been changes in this entity over time? And we can determine if new images are needed. Perhaps we want to monitor this through time. Maybe you want to say that we will take our next cone beam CT in maybe 3 to 6 months and look for a growth potential. And that could let us know if there's something actually going on within the maxillofacial region. So when we are coming up with a sequence, the very first thing that I like to do is I like to look overall at the cone beam CT scan. I like to have a global approach. And I do this more in my axial and my coronal sections because I can use symmetry, which we'll talk about later on. But definitely we want to be able to evaluate and compare one side to the other, look at the cortical boundaries. We can't differentiate soft tissues with cone beam CT. So we need to be really good at following those cortical boundaries so we can tell exactly what's going on. And of course, you might want to count the teeth. Make sure that we have the appropriate number, or maybe we have supernumeraries. When I go to look at things a little bit more locally, I use the sagittal sections to do that. And that way I can really look at the periodontal ligament spaces very well, the lamina dura. You can evaluate your root form and your canal structures and assess the crowns for any type of abnormalities. Now, if you find something and you don't know what it is, feel free to put the crosshairs right on that region of interest and look at it in all three planes. But I do go through all of my scans multiple times in all three planes, and this is what I have found has really helped me as far as looking at things globally first and then moving more locally. So we're talking about radiographic interpretation. What is it? Well, that's the ability to see and understand what is revealed by a radiographic image or a cone beam CT. And that seems very self explanatory, but we have to first be able to see something and then understand what it is that we are looking at. And sometimes when we're first starting to look at our cone beam CTs, we're not quite sure if we're number one, seeing something, and number two, we may not understand what it is we're actually looking at. Just know in this area, there is a learning curve. Don't feel bad if you look at everything and think that there's pathology everywhere, because that's how I started out as well. But we do know there's a learning curve. So what you see in maybe, 1 to 2 years from now is going to be far more than what you see today. And you're going to learn that you can trust your 3D imaging. So we also want to consider our interpretation principles. Our number one principle being able to recognize our normal anatomy. We want to have a mental picture of what that normal anatomy is as we go through our scan because it helps us to be able to determine what is abnormal. So if it doesn't fit into what the normal anatomy should look like, maybe we have a pathology. Interpretation principle number 2 is our principle of symmetry. And I really love this. I think it makes it really easy for us, especially when we're first starting out evaluating a cone beam CT. We can use our axial and our coronal sections to compare one side to the other. So if both sides look exactly the same, very high likelihood we are just looking at anatomy. Now, not all of the pathologies have read our textbooks, and very occasionally we will see a bilateral pathology, but it's extremely rare. And so we can use our axial and our coronal sections as you're scrolling through to compare the right side to the left side. If everything looks nice and symmetrical, we know we're doing okay. And that's what we teach any of our new residents coming in as well, is that you're going to want to use symmetry in the very beginning. It is definitely your friend. And then, of course, all of the anatomy you will pick up as you're going through. You'll start to remember it all from your dental school days. The best part about radiology is that it doesn't smell. So it's a lot more fun than going through our anatomy and cadavers and that sort of thing. Um, but I think this is a really easy and simple method to start out looking through everything. So here's some examples of using symmetry. And you can clearly see that we have a difference between our right side and our left side. And we can definitely see this in our coronal sections, not just the axial sections. So even if we don't know what this particular pathology is, we can look at one side and say, this is different. It doesn't look correct. It looks like something is out here kind of pushing in on the bone. We've got some remodeling of cortical borders. We do have a large lingual tori, but it looks like we have a little bit more than that. And so that's our anterior Staphny bone defect. But again, even if you didn't know that, you would realize something is different, and I want to refer this out to a radiologist to be looked at for further evaluation. The same thing with this one over here. We can see that the side is very, very different than that side. We have expansion going on. We have thinning of cortical borders. If we look in our coronal section, we can see that the tooth has been displaced. So we know there's definitely a pathology going on that particular side. And again, even if you don't know what that is, even, if you don't remember from your pathology days, you'll send that out because you have been able to see it and you understand that you do have a pathology going on. As one of our professors used to say, you may not see pathology in your practice, but pathology will see you. So being able to see it is a really big deal. So that's fantastic. And using SYMMETRY is such a great tool. So simple and easy. Principle number 3 is that regardless of our imaging modalities, the radiographic signs of disease are going to be the same. So, for instance, if I am looking at maybe a cystic process in 2D, it's going to look very, very much the same in 3D. You're still going to have a hydrostatic appearance, expansion of cortical borders, that sort of thing. And so we can still see that we have the same radiographic signs based on just imaging characteristics. It doesn't matter if it's 2D versus 3D. And so you're really not having to reinvent the wheel. Cyst looks like a cyst. A tumor looks like a tumor, that sort of thing. And of course, we want to come up with our radiographic signs. So as we're evaluating our entity, we're going to be describing it. And really, in describing what we're talking about, it lends us toward a particular category of disease. So it's very helpful for us that way. So things that we look at, location and distribution. Uh, for instance, is this in one location? Is there only one entity? Or are there multiple entities? Is this bilateral? Or maybe this is all throughout the maxillofacial region. What about shape? Well, if it's a shape that you learned in kindergarten, so you didn't know that you were learning about radiographic interpretation in kindergarten, did you? But if it's a shape that you learned in kindergarten, it is most likely benign, which is incredibly helpful to us. What about size? Is it large? Is it small? We can look at our marginal characteristics as well. Is it well defined and corticated, or is it ill defined? And that can tell us a little bit about the aggressiveness of that particular entity as well. We can look at radiographic density. Is it radiolucent? Is it radiopaque? When we talk about it in terms of cone beam CT, we're really going to talk about it in terms of density. So is it hypodense? Is it hyperdense? We can talk about internal architecture too. Is this unilocular? Is it multilocular? And we can talk about effects on surrounding structures. So what is it doing to the cortical borders? What is it doing to the mandibular canal? What is it doing to the teeth? And this all lets us know, of course, again, how aggressive a particular entity is. And you see that I have underlined marginal characteristics and the effects on surrounding tissues. Those two really tell us about the biology of a particular entity. Is this aggressive? Is this much more benign? That sort of thing. So those are two really important ones to keep in mind as we go through our scan. All right, so let's go ahead and go through a scan and let's talk about it. So I always start in my axial sections. That's just where I like to start when I go through a scan. And I always start up at the top, usually right in the frontal sinuses. I like to review my sinuses first. The sinuses are something that will not be symmetrical. Just know that. And as I go down, I can look at my ethmoid sinuses, my sphenoid sinuses. We get into our maxillary sinuses. We can look, for instance, at a deviation in the nasal septum. Always looking at cortical borders, making sure everything is smooth and intact. We can get down into the maxilla. Again, I'm looking at my dentition as well as my cortical borders. At this point, I'm going to hop back up to the condyles because I want to have a smooth swoop down through my mandible. So I'm going to hop back up, grab my condyles. I want to look at those. I want to make sure we have smooth and intact cortical borders. We can go ahead and put our crosshairs on those if we're concerned about it. We can look at them in all three planes. But again, as I extend down inferiorly, I am looking for my intact cortical borders, looking at symmetry, because we know this is going to be very symmetrical. Make sure the right side looks very similar to the left, all the way down through, and then I'm going to come up through the airway space. I can look, for instance, at the epiglottis. We can look at the hyoid bone. This is the level where we might get calcified carotid atheromas. So you might look for that as well. As we go up the airway space, we can look, for instance, at a limited airway space. Patient might have enlarged tonsils, and all the way up to the nasopharyngeal region. Once we're in the nasopharyngeal region, we have the torus tubarius, and right behind that is the fossa of Rosenmuller. We want to make sure that that's pretty symmetrical and intact. We know things like to exist in this area, so we want to make sure it's fairly symmetrical. And then on up into our cranial base. So, for instance, we can look at the horizontal portion of our internal carotid arteries. We might want to look at our external auditory canals, and we can look at symmetry. We can see the ear bones. We can see the internal auditory canals as well, and our mastoid air cells. They should be fairly symmetrical, but sometimes mastoid air cells will pneumatize, and they can pneumatize anywhere throughout our temporal bone. As I come back down, I'm going to be looking at the more posterior aspect of the scan. I'm going to look at the cervical spine. I want to make sure things look fairly symmetrical. We can see our cute little odontoid process. That's our little protuberance that we have on C2. We can look at the transverse foramen, make sure that they're fairly symmetrical. And as we go down through again, we're going to look at our cortical borders, making sure everything is smooth and intact. And at this point, I have finished going through my axial sections. I'm going to start on the coronal sections. And I always drag the crosshairs to the front. I'm going to do the exact same thing that I just did in the axial section. I'm going to pick up looking at the superior 1/3 of our scan, which again is going to be our frontal sinuses. We can see, of course, our maxillary sinuses, the nasal fossa. We might try to find our osteomeatal complex as well, because that's the opening, the drainage for the sinus. So I'm going to make sure that that is open. We can get into our ethmoid sinuses, make sure everything looks smooth, intact, and back into our sphenoid sinuses. Now remember, sinuses will be asymmetrical, and that's kind of the rule for sinuses, but most everything else should be fairly symmetrical as we go through. We can see foramen rotundum, some of our other foramina as we extend through. We're going to see foramen ovale as well. So a lot of great foramina within that sphenoid bone. Sometimes we'll see calcifications superolateral to the sphenoid bone as well. So we might have internal carotid calcifications. We can definitely see the internal carotid as it kind of turns and looks like it heads south. It's actually coming up. We can look, of course, external auditory canals, the ear bones, the semicircular canals, and back to those mastoid air cells. Remember, the air cells do like to pneumatize a bit, but they should, on the whole, be fairly symmetrical. So all the way back through, all the way to the posterior, make sure you view the entire volume. Then I come back anteriorly, and I'm going to pick up looking at my cervical spine. I want to make sure that everything there is smooth and intact. Cervical spine looks great. I'm going to pick up on my condyles, and I'm going to kind of swoop through anteriorly, looking at the mandible, comparing symmetry, looking at cortical borders, making sure that everything looks like it's nicely intact. Once I come to the anterior, I'm going to do one swoop back, just looking at the maxillary dentition, because I really didn't pay attention to that when I was looking at my sinuses the first time. So just one swoop back to look at the maxillary dentition. Once I hit sphenoid bone, I know I've evaluated all of that. Next, we're going to start over on our sagittal sections, and I always start at the right condyle. I'm going to swoop around the mandible to the left condyle. Now, this patient actually has a subcondylar fracture. This was not picked up in the ER, and this particular patient was complaining of issues with their bite. But we could see it very clearly with our cone beam CTs. Again, I'm going to look at periodontal ligament spaces in the sagittal section. Notice I can't compare symmetry in our sagittal section, but I can see the periodontal ligament spaces very, very well. So this is where I'm going to look more locally at my scan. Over at the left condyle, we're going to look at that, evaluate it, and then we're going to go from left to right through the maxillary dentition. And again, looking locally, we are looking at those periodontal ligament spaces. Want to make sure that everything looks fairly nice. We can evaluate very easily any of our root canal treated teeth. And of course, we could rule out any sort of sinusitis that is a result of an odontogenic infection. Then I make one swoop back. I'm going to look at my pterygomaxillary fissures. Make sure those look very nice, cortical borders intact. Look at some midline structures as well. We'll look at sella turcica. We can see the clivus. We can see the cervical spine. And we can see our incisive canal as well. This patient happens to have a very thin one. And then continuing over to the left side, I'm going to look at the pterygomaxillary fissure on that particular side. And at that point, I am done. So I know it probably took me about 7 minutes to talk about, but that's because I'm talking about it with you. But it really doesn't take very long to be able to evaluate the entire volume. And once we do, if we see any radiographic signs of disease, we'll want to determine, are we looking at something that is normal or abnormal? So that's always the decision that we're trying to make. Is it normal or abnormal? And one of the things that really helped me when I was learning how to do all of this, um, when I was first a resident, the gal that was the chief resident said, Heidi, if you think you see something, what do you think it is? And that's just a really simple statement. But if it doesn't really fit into a category, you're probably seeing something normal. So the very first thing I want to decide, normal or is it abnormal? And if you're looking at it, you're going, you know what? I've never seen that before. We've got asymmetry. I really think this is abnormal. Well, what are some really common abnormal things? It could be developmental congenital, or it could be something that is acquired. So when we're thinking about things that we might be looking at, we want to think of things that are common. For instance, if you hear hoofbeats, don't think zebras, you're going to think horses. So we want to think about common things because they're common. So if you're looking at this saying, you know what, there's no history of any type of developmental congenital issue. This is definitely not anything that I learned in dental school as developmental congenital. Then we're going to start thinking about things that are more acquired. And again, thinking commonly, trauma and inflammation. Incredibly common. And as dentists, we are excellent at diagnosing trauma and inflammation. And this is going to comprise about 95% of what we see within our scans. But the other 5% might be a little bit more interesting. If, for instance, the entity looks hydrostatic, looks like a water balloon filling up, we might think about a cyst. What if it's mixed density? Well, we might think about a fibroosseous entity. Perhaps it doesn't meet any of those criteria, and we start thinking, wow, I've got some expansion of cortical borders, or maybe I've just lost cortical borders. So you might start to think about a tumor, like something benign versus malignant tumor. And then the last one I do think is the most difficult. That is our systemic or metabolic. But the key to that is it's generalized. It's everywhere. Whatever it is you're seeing is in the mandible bilaterally. It's in the maxilla. It's in the cervical spine. So if it's everywhere, we start thinking about something that's systemic or metabolic, and we come up with an impression of what we think we have. Once we have our impression, we can start thinking about management of whatever this particular entity is. We know the majority of cone beam CT scans will reveal incidental findings. And in all of the research that is been published, as well as in our private practice, we tend to see about 3 to 4 incidental findings per scan. It's incredibly rare to go through a scan and not find anything. So just know you're going to see about 3 to 4 incidental findings per scan. Now, majority of these really require no treatment. It might be something like a dense bone island. You might have some physiological soft tissue calcifications that really don't matter. But some things do need monitoring. So about 29% of the things we find are going to need monitoring or additional imaging, which means we're going to reevaluate this perhaps at a different time, or we're going to say we have hard tissue and imaging with cone beam CT. Maybe we want soft tissue imaging. So maybe we want to have an MRI. About 28% of findings will need additional treatment or referral to another specialist. And in all of the research that's been done, I would say probably this is one of the latest research um, projects down here. They found in this particular cohort, the majority findings were in the dental alveolar region. So we're thinking about periapical lesions and that sort of thing. Next, we would find airway. So maybe we have a limited airway space. Next, we might have soft tissue calcifications, which of course you'll see more soft tissue calcifications as a person ages. Just expect that the older the individual is, the more incidental findings you're going to find. Temporomandibular joints, perhaps we're seeing osteoarthritic changes. Or there may be something going on in the bone, like a dense bone island. About 2% of this particular population in this research showed a lesion of the jaw. So in their cohort, only 2% actually had a lesion when they went through the cone beam CT. And we're talking about some type of odontogenic or non-odontogenic pathological entity. And then 2% was put into the other category, as in we may not know what exactly that was, or maybe it's just a variation of normal. So our actions for approximately the 30% that we have to do something with, we're going to either monitor, they might need further imaging, other diagnostic tests, maybe vitality testing. Maybe we need to go back and do a clinical evaluation to try to correlate what we've seen in our scan. Perhaps we are looking for that drainage that I talked about previously. We're trying to decide whether we have a chronic inflammation versus a malignancy. And then, of course, as we talked about 30% will probably need treatment. Next, we come to planning. We want to plan the overall treatment. And we know that with cone beam CT, we have a more accurate diagnosis and treatment planning than we did with 2D. But really, our cone beam CT is much more than that, and it becomes the foundation for our digital dentistry. You can pretty much do anything that you want to with your cone beam CTs because they're made out of DICOM files, and that's a detailed specification standard for communication and imaging information. And so, what that basically means to you in layman's terms is you can take your scan and put it into thousands of different types of software and do pretty much anything you want to under the sun. If you decide you really want to do a lot of 3D modeling, 3D printing, that sort of thing, you can definitely do that. But again, if you can dream it, somebody can code that for you, and you can pretty much do anything you want to with this amazing technology. It's also fantastic for your patient education. So this is really ideal for being able to show Mrs. Jones exactly what it is that we're looking at. So excellent for that. What I do want to really stress though, with any technology, we want to continue to learn. Cone beam CT is no different. Now, there are some courses that are provided by certain manufacturers. These courses are free because they're included in the price of your CBCT. Take advantage of that if you can. We do find that only 60% of dentists actually go back and take the free courses that the manufacturer offers. And I would say that number should really be 100% because we are looking at a totally new technology. We are not born knowing this. And this is fantastic offering from the manufacturer to provide you with a free course to tell you how to use your machine and help you understand what it is you're seeing. But I would also say join a multidisciplinary study club. You could be just a huge asset to that study club with your 3D imaging and your knowledge of 3D imaging, but you can also learn a lot as well. Learning centers such as Spear, there's multiple ones all over the country. You can go and take courses or you can do online courses. Of course, there's many books that we can use. I think one of my favorite for radiology is Oral Radiology Principles and Interpretation. Fantastic book. It's great, beginner-friendly book as well. Of course, Netter's Anatomy. We all probably still have that left over from dental school days. Your anatomy actually doesn't really change. So you can pull out that book and start going through that and looking at your scan and comparing what you're seeing. And there's, of course, online resources. Fantastic. Radiopedia.org. You'll notice the spelling is a little bit different. It is a resource that is out of Australia, and it is medical radiology, but the technology you have is really a crossover between medicine and dentistry. And so they'll go over lots of different anatomy and that sort of thing. They also have a bunch of pathology on their websites, and you can actually search things. So as long as you know what to look for or what to describe, you can see a whole host of various pathologies you might have. E-anatomy, that's another fantastic one I would highly recommend. And I think all of this is just kind of to remind us what Albert Einstein said: never regard study as a duty, but as the enviable opportunity to learn. This is a fantastic opportunity for you and so exciting to continue learning over time. Now, I do have to put in ethical and legal responsibilities. I know people are very concerned about it. What is our ethical and legal responsibility as dentists? Well, the entire scan volume should be looked at. That's why we look globally first and then we moved more locally. Many times we just want to look locally. We want to just look at the teeth and we ignore everything else in our scan. But it's very important, especially to your patient, that you scan the entire volume or evaluate the entire volume. We want to be able to recognize abnormal and refer appropriately as well. So again, if you ever are concerned, you're not sure what you're looking at, you can always send to a radiologist. Free training is offered by many manufacturers, as I stated. And again, there are oral maxillofacial radiologists across the country that are more than happy to help. We're very service oriented. We are very excited to be able to be part of your diagnostic imaging team. We know this is not something that we're born knowing. And so we're definitely here to help, and just kind of think of us as the radiologist in your pocket. So we're here for you. And remember, everyone can take this opportunity to thrive. But who is the ultimate winner in all of 3D imaging? It's definitely the patient. Thank you so very much for sitting with me today and going through how to read a cone beam CT scan. I hope this was helpful to you. And I know I had a ton of fun. Um, I just love getting to review everything, and you really can't have more fun than radiology. So thank you very much.